The topic of my presentation is a first-line treatment strategy in patients with low tumor burden. As you know, the natural history of metastatic renal cell carcinoma is highly unpredictable, with up to 15 of patients who can need no treatment. And because targeted agents, anti-angiogenic agents, rarely achieve durable remissions, the impact of treatment must be balanced against toxicity, duration, and costs. And observation can be a viable option in patients with low tumor burden sometimes. But what do we know about patients with low tumor burden? We have some data suggesting higher efficacy of treatment when tumor burden is low, and on the other hand, we have some data suggesting equivalent efficacy when the treatment is delayed. We know that thyroid and pancreatic metastases appears after long-lasting disease and are usually associated with good outcome. And we also know that some cases of spontaneous regressions of metastases has been reported, and metastasectomy has a role. So the role of tumor burden has been already highlighted in the previous presentation. Just to tell again that to start treatment when the tumor burden is low is associated with a better outcome. On the other hand, if you look at the target trial that has compared sorafenib to placebo, as you know, 50% of the patients on placebo crossed over to sorafenib treatment, and there was a survival advantage after crossover, as you can see in the graphic on the right side. So this improvement in survival after crossover is obviously consistent with efficacy of delayed treatment. Another important factor that we have to take into account is the age, because from this analysis on over 11,000 patients, we know that younger patients are more likely to have more than one metastatic site, thereby making observation in these patients harmful. And the role of resection of a single lesion has been well established, but we still don't know, it's not well defined, the role of multiple resection. And this study, the complete resection of multiple metastases has been shown to be associated with long-term survival. And the resection of multiple metastases thereby should be considered when technically feasible in appropriate surgical candidates. Obviously, the advantage is higher for patients with lung-only disease, but it's also significant for patients with multiple sites and with asynchronous metastatic disease. So, putting together all these data, we can draw a profile of a patient who we can observe. Probably older patient with a symptomatic disease, with low volume in favorable sites, patient with slow-growing, unresectable disease, significant comorbidities, and anxiety under control. And this is the profile of the patient that we probably have to treat. So younger patients with a symptomatic disease, low volume but in unfavorable sites, for example, liver, fast-growing disease, and surgical candidates. So let's go through two cases. This is the first case. The first case is a 75-year-old businessman with post-medical history was not relevant, who underwent in 2001 a left nephrectomy for the clear cell carcinoma PT3A-G2, and after 4 years he developed multiple lung nodules that were resected bilaterally, and then in 2006 he developed again lung disease plus 2 pancreatic lesions and 1 thyroid lesion. So interferon was started with this patient, but he had progressive disease after 4 months, and the patient was enrolled in the phase 3 trial with Sorafenib, but the treatment was stopped after 4 months because of liver toxicity with a stable disease. This was the situation when the patient stopped Sorafenib. So we decided to observe this patient. And after 4 years of observation, the situation was absolutely identical. And this patient had no treatment at all. After a few months, he developed, after 4 years again, he developed a progression on the thyroid lesion, on the pancreatic lesion. A surgery was proposed, but he had to do a Whipple resection, so he refused. And sunitinib was started with partial response. But after 8 months, he developed grade 3 GI toxicity, So after recovery, sunitinib was restarted and then stopped because he had again toxicity. At the moment, the patient is again under observation. So this patient undergo 3 surgeries, 2 different types of therapies, and observation. The second case is a 65-year-old male with past medical history relevant for hypertension and benign prostatic hyperplasia, who had a diagnosis of a left renal mass with bilateral lung nodules, who underwent a nephrectomy. It was a clear cell carcinoma PT3F, Rumen grade 3, and this patient we tried to enroll this patient in sunitinib plus enzostatin study, but at the first evaluation there was a reduction of the lung nodules that he had at the beginning. That we had no measurable lesions, so we started observation. After a few months, one of the lung lesions disappeared and the other was decreased. This was the prognostic profile of the patient. But after 2 months, this patient developed neurological symptoms, and the CAT scan developed of the brain multiple brain metastases. At that moment, the lungs were clear. So I think we have 2 open questions. When do we have to treat a patient that we are observing? And the second is how to treat these patients. I think we should need some factors. Some of these factors could be patient-related, such as symptoms, anxiety status. Other factors should be tumor-related, such as the growth rate or the appearance of new metastatic sites. And also the tumor-host interaction can be important in our decision-making process. The growth rate of small renal masses who have undergone surveillance have been observed in this study. And the risk factor for developing metastatic disease were the initial greatest tumor volume, more than 66 cubic centimeters, the linear growth rate, and the volumetric growth rate. And none of the patient with zero net growth progressed to metastasis. But can we apply this also to metastatic disease? We don't know. And we know that inflammation has been now considered the 7th hallmark of cancer. In this study, serial measurement of the C-reactive proteins have been associated with the tumor status. And furthermore, C-reactive protein is inexpensive and readily available. So the second question is how to treat these patients. I'm going back to the study that has been presented yesterday regarding the intratumor heterogeneity. If you look at the slides, if you look at one of the Darwin drawings regarding the origin of species, the similarity between these 2 pictures is impressive. And this, in my opinion, has 2 meanings. The first of all, that the progression of the tumor is a selective process, but the microenvironment probably can give an advantage to a clone over another. And the second message is that you can act in this part of the bar before the development of multiple clones. Probably you can have an advantage. And in a slow-growing disease with low tumor burden, there is probably an equilibrium between the cells, the tumoral cells themselves, and the cells in respect to the microenvironment. If you try to treat this patient and the bottleneck of your treatment is too narrow, you probably could select a resistant population. So the goal of treatment in patients with slow-growing, unresectable, is to maintain a stable volume by adapting the treatment as the tumor evolves. For patients with resectable disease, low volume but resectable disease, probably our approach should be more aggressive. I think that we can cure some of these patients, but we have to increase the number of complete responses by surgery, I don't know if by combinations or with intermittent therapy. This study has highlighted this kind of behavior on 36 patients treated with sunitinib, sorafenib, bevacizumab, interferon, or temsirolimus. Treatment was discontinued after the achievement of or a complete response by treatment, or after the achievement of a no evident disease with surgery. 24 patients recurred, but the re-exposure to the same drug or to another drug was effective in 86.9% of these patients. So in conclusion, low-volume disease is a highly heterogeneous disease, and early treatment must outweigh the toxicity and costs. Delayed treatment must outweigh the risk of progression. The maintenance of tumor volume is the goal in slow-growing, non-resectable disease, while the complete clearance with targeted therapy and surgery is the goal in more aggressive resectable disease. Intermittent therapy is also an option that must be validated. Thank you very much for your attention.